All right, with that, let's get into the story. I mentioned my team here at the office and my family. That's me and my one day a year cowboy hat. That's at our Christmas party not too long ago. That's my wife, the blonde. Next to me, beautiful wife. We celebrated our 46th anniversary a couple of days ago. Been together a long time, and she has blessed my life. And all these other people are my extended family, my staff that's worked with me, and it's a pleasure to come to work because I'm not with strangers. Most of these folks have been with me 12 years to 30 years, and so it's just been a way to really enjoy practice. I don't feel burnout. I feel like I'm just getting started. And you mentioned, Damien, that implants have been my passion, and I'm involved in orthognathics and TMJ surgery and of course lots of wisdom teeth and everything, but implants has always been something that I really loved and have focused on. And so as that implant practice grew and the years began to accumulate, I saw about 2008, 2009, my heart began to break at more and more cases I was seeing that were beautifully done both surgically and restoratively, and these patients were coming back with sick implants. And I tried everything I could think of, and I would get a little encouraged here and there, and then it would go south, or there would be no benefit whatsoever. And so I did a literature search to kind of see what I could find, to see what I was missing, and there I found this great review article from the consensus report of the 6th European workshop on periodontology headed by John Lindy, published in 2008. And in this extensive review, they found that nothing was working. It wasn't just me. Nobody was having success. And everybody was seeing this big explosion, this almost epidemic-like problem with implants getting sick with peri-implantitis. You'll see number 2, there was some promise with laser therapy that needed further study. And so it was similar to my experience. And because I had just using a diode, an expensive diode laser, I thought I saw some things there that I wasn't seeing with any of the other things I was doing. And so y'all mentioned my large Seattle study club. I've been blessed with one of the largest in the country. Most years we're somewhere between 50 and 60 members. And so I was giving them a talk one evening on peri-implantitis, and I was presenting that review article, and I mentioned the fact that the diode laser was about the best response I'd seen, but it wasn't great. And after that presentation, a dentist walked outside with me, followed me to the car, and he said, "Gary," he says, "did you read anything about LAPIP?" I said, "Well, what?" He said, LAPIP, LAPIP, Millennium Laser. I mean, they were Greek words to me. I had no idea what he was talking about. And my coordinator for the study club is also my treatment coordinator. And this gal, I mean, she doesn't let grass grow under her feet one day, or my feet. She gets after it, and she's a big part of my success. And I'm telling you, that next week, she had the rep here in my office telling me about this Millennium Dental Technologies, about this YAG laser they had, and about this protocol for teeth called LAPIP, which stands for Laser Assisted New Attachment Procedure, and this protocol they had for implants called LAPIP, which is Laser Assisted Peri-Implantitis Procedure. Well, that didn't mean a whole lot to me until he started showing me some of the research. And I saw some stuff I'd never seen in my life. This paper by Ray Yukna, the histological evaluation of the YAG laser assisted new attachment procedure in humans in the International Journal of Perio in 2007. And I saw the histologic proof of bone growing back in a pocket where there was previously not bone. Elimination of a pocket, not by mutilating the patient and lowering the tissues on the root to get rid of the pocket, but getting rid of the pocket by growing bone back where it used to be gone. And then this follow-up paper from 2012 by Mark Nevins, another histologic study. I mean, I couldn't believe it. I just couldn't believe it. But what about implants? Well, there were no studies he could show me, but he showed me a handful of remarkable results where bone grew back. And I said to him, I want it. I mean, it was, back then, it was well over $100,000, well over that. Of course, they've gotten a lot more affordable now, but back then, I mean, they were really expensive, but dude, I was ready to buy because I wanted some way that I could help my patients with sick implants and not just watch them burn up and eventually die and lose all that investment and be left with a problem because now you have lost bone. I mean, you know, it's just, it's a goat rope and goat show when those things get sick and start going. And so I needed something. And he said, well, you can give us a $5,000 down payment, but you can't get your laser until you pass the course, until you take the training. And I said, training's required? Well, let me tell you something. It's lots of training and it's impressive and it's essential. I know that now. But I mean, it's amazing amount of research, amazing amount of study that has gone into this, and they required of their students. And that impressed me so much, and it still does, because there's some lasers out there on the market that claim to do the same thing and don't, and there's no training hardly whatsoever as well. There's no protocol. And I learned how important it was to do things right, to treat peri-implantitis with a laser. I learned that there's a number of things true. Hey, Ray, this over here is blocking out some of, is there a way to, I can't read some of what I've got up here because the pictures over here are blocking it. See what I'm saying? There you go. To treat peri-implantitis with a laser, there are a number of things that need to be true. First off, it needs to be evidence-based, and we know what that means. It means there needs to be research behind it in peer-reviewed journals, so you're not just out there flying by the seat of your pants, and there needs to be FDA clearance. I can't imagine using a laser to treat peri-implantitis that can't say this. There's some that try to ride the coattails of what Millennium's done. I don't believe that's a very safe coattail to do it that way. The laser you use needs to be evidence-based, FDA cleared. And then it needs to be an YAG laser with a wavelength of 1064. I'll show you in a minute something to put that in perspective for you so you kind of understand where that is. And why that's important. But it also needs to be high frequency and pulsed with very short duration pulses in order to help dissipate the heat and not damage the good tissues. There are a number of other things that are true. Before we get to that, let me show you this chart on wavelength, the electromagnetic spectrum of light. This is kind of complicated, but to break it down for you, over on your left side of the screen, that's the invisible ionizing radiation, where we have X-rays and ultraviolet light. And then right there in the middle, that little narrow band there between 400 and 700 nanometers is the visible spectrum of light. Then over on the right is the invisible thermal radiation area as the numbers begin to go up. And there you find down here the YAG laser on the bottom right, mid-right is 1064 nanometers. And that's the sweet spot where some magical things happen that don't happen anywhere else. When you get too far to the right, where you see the erbium YAG and the CO2 laser, those are fantastic for cutting tissue, way better for cutting tissue than the YAG 1064 laser. But I didn't buy my YAG laser to cut tissue. For me, in my hands, I'd rather use a blade or a cautery. I mean, it's like you can't use one gun to hunt every species of animal. You can't use one implement to do an entire farming operation. There are different tools for different things. And what I want from my laser are the things I'm going to show you today that it will do for me, that this erbium YAG and the CO2 laser and some of the YAG wannabes that claim they're doing things that's not true are not going to do for you. So what else did I learn was important? Well, there needs to be tissue penetration past the probing depth. And the YAG 1064 laser will kill bacteria 2 to 3 millimeters beyond the laser tip as it penetrates on in. That's proven by research, evidence-based. The Peri-Implantitis biostimulates 4 to 6 millimeters beyond the laser tip. And we're going to talk about biostimulation more later on. So if you don't understand what that is, you will when we finish. This is important, really important. There needs to be variable absorption towards pathogenic material versus good tissue. Why is that? Because it helps your therapeutic index ratio tremendously. The Millennium Nd:YAG laser, for example, has a therapeutic index ratio of 2.5 compared to only 0.5 for the diode laser. Well, that means when I was using that diode laser ignorantly, without training, without even knowing what I was doing, I only had to, it took only twice the energy to kill good tissue versus the energy it took to kill the bugs. That's not a very big therapeutic index ratio when you look at the Millennium laser. 2.5, you know, 5 times that amount of energy has to be given into the tissue to kill gingiva or bone compared to what it will take to kill the pathogenic bacteria and break up the mucopolysaccharide smear layer. That's a huge benefit to you. That happens only at that magical wavelength of the Nd:YAG laser. There needs to be a proper size fiber diameter. And they found through their research that the 360 was that was the home run micron fiber that worked the best. Now there's times that you cut it back to 320. There's times you can cut it up, increase it to 400, but the sweet spot seems to be 360 for most cases, because that's when the smaller the fiber, the less energy can pass through it in a moment of time, and vice versa. 360 is that sweet spot. Research showed them that. This is really important. You have to have a calibration capability so that you can calibrate your machine before you begin treating the patient to know that it's putting out the energy that it says it's putting out. And there needs to be standardization to allow for known dosage being given. This is the only one that's an Nd:YAG laser that does that for you. And then, like I said, man, you gotta have that extensive training so you know what you're doing, and you protect yourself from government oversight. You protect your patients. You protect your practice and your family from not being sued and lose it. And then last, there needs to be a research-based protocol. What's a protocol? It's an A to Z way to do what you're doing to increase your chance of success. I remember one of my dear friends and that we've lost, Carl, drawing a blank, Carl, the prosthetic implant guy that died recently. I loved him to death, but he used to say something in his courses he would give. He said, a guy raised his hand. He said, well, can't you do this? And Carl said, there's a difference between what you can do and what you should do. What you can do is what's going to give you success some of the time. What you ought to do, or what you should do, is what gives you success most of the time. And that's where this protocol becomes so important. You're just not out there doing willy-nilly, but you're following a plan that's based on research that will give you success most of the time. And here's their protocol. If we follow through from 1 through 8, number 1, first under anesthesia, you confirm the depth of the pocket. Then number 2, you come in with the laser set on ablation, which is a higher energy setting that's going to go in and kill the bacteria and break up the mucopolysaccharide smear layer, help begin breaking up any calculus and cement that might be in there. And then number 3, you come in and with an ultrasonic piezoscaler, spraying chlorhexidine rinse, you clean out the pocket, again, trying to get the smear layer off, the cement out, the accretions out, the calculus out. And the last step in that, you go in with a sharp tip and you scrape the bone really hard, number 4, to stimulate bleeding, because we want to get this space where there was bone loss to be filled with a blood clot to guide the regeneration and the formation of the bone. Theoretically, it also may and probably does release some healing factors as well that assist in this. Number 5 is the hemostasis step being done. The energy levels are lowered here at the hemostasis setting, and it encourages coagulation at that point. Number 6 is taking your fingers and bluntly recompressing the tissue back against the tooth or the implant. And then number 7, so critically important to both LANAP and LAPIP, and I have so much respect for Bob Gregg and Dawn for recognizing the importance of this. and that's the occlusal equilibration. Huge percentage of my implant cases I found were in hyperocclusion, heavy occlusion. And the Millennium effort is to shift most of the forces from the posterior teeth, lighten those up, and move them towards the canines whenever possible. Because whenever those canines hit, it just turns off neurologically the power to the muscles of mastication and helps reduce the forces to the tooth. And it's just magical how that works. If you ignore that, you're going to get burned. And then, of course, number 8 is just allowing the healing and regeneration process to begin. And Millennium has a long set of recommendations for what to do when patients go home. And we're not going to go over all that today because my purpose is not to teach you how to do this. You got to go do that yourself with the course. My purpose is to expose you to the big picture. So anyway, I came back. I got certified. I got trained. I got my machine. I came back. I started treating patients. And, you know, after about 6 months of doing this, 9 months of doing this, I had tons of patients I was doing. I'll show you those numbers later. I found what was working. I got excited about it. And I said, you know what? I want to do a paper. I want to do a research paper and present my findings. Now, if I'd have known what that was going to cost in blood, sweat, tears, and money, I don't know if I'd have ever done it because I had no idea what was involved. Nor did I have any idea how hard it would be for somebody who's never published anything other than my graduate research paper from doing my MSD thesis at Baylor many, many years ago. But I'm pleased now that it's done and it's behind us because I think it's a big contribution. And so I hired Dr. David Harris to be the co-author on this paper to design the study. I'll go over that here in a minute. And so here's what we did. Dr. David Harris, who at the time was employed by Millennium, he no longer does that, but I'll show you his credentials here in a bit. So he designed the study and wrote the majority of the paper, designed how we were going to do the statistics. I performed all the LAPIP surgeries. We looked at a period of time from 2013 when I began to 2016 when we closed it 3 years later, and I'll show you all that in a minute. And we reviewed all of those patients that had received LAPIP in those 3 years following my training. Now, in the beginning, we weren't as diligent about keeping perfect data on everybody. And so all patients were included to eliminate selection bias. They were included. And during treatment, everyone was blinded. Since the study was retrospective, there was no way to be biased when we did it after the fact. And we got an IRB approved data collection protocol to be free of bias and approved the case report forms that were used to capture the data that we recorded. I hired a hygienist to probe all of my patients and enter the data for each implant and patient on data sheets. The hygienist then went through the medical records and entered all information required by the study design on the case report forms. The case report forms were then scanned by her and uploaded directly to the statistician for data entry and analysis. And the statistician is the one who excluded the subjects that were to be excluded. And they were only excluded because complete data was present, not for any other bias possible reason. And the authors, me and Dr. Harris, were not involved in that process at all. So I did the surgery. Harris wrote the paper. The statistician took the data and decided which ones to keep, which ones to throw out. Now, between the time that I started my study and finished the first study, we've got a longer term one we're doing now. More research began to trickle out. First was this paper from Algraphy in 2020 in 12 in the British Journal of Oral and Maxillofacial Surgery, confirming what we had found already from Lindy's study. There's no clear choice and there's high failure rates in everything that had been published to that time. That's 2012, a year before I started my study. A year after I started my study, this great paper from Eli Mokti, a huge review of the literature. He looked at non-surgical treatment possibilities, and he looked at surgical treatment options. And what he found was the same thing everybody else was finding. He said peri-implant diseases are becoming a major health problem, and the literature is still lacking in clarifying, predisposing, and directing treatment protocols. And his conclusion was, therefore, at the present time, treatment of peri-implantitis should be considered possible, but not necessarily predictable. Why? Because there were these occasional great results, but not consistently. And that's 2014. The one thing that continued to be mentioned that gave me encouragement in the literature review was the same thing I'd seen, that laser showed some promise. And then this paper came out by Maloa in 2014, in which he explained why we were seeing some of that promise. Same thing I saw with the diode laser way back there. And that's it. Virtually all dental laser types have been demonstrated to be effective for decontamination of implant surfaces, but most provide only marginal improvement in clinical efficacy when combined with other therapies. So obviously, if you clean the implant surface, you're going to see a beneficial short-term effect. But if that's all it does, it's going to be temporary at best, and that's what the studies were showing. So I was bullish on the fact that we were going to have something that would be contributory to the literature. And then in 2014, also this paper came out, the first on the LAPIP protocol, published by Dawn Nicholson Gregg at Millennium, the Dawn that I mentioned in charge of research at Millennium. And what they did was they had all of their students that had gone through the training, their LANAPers and LAPIPers, as they call them, to send in their single best case of treating an implant for peri-implantitis with the LAPIP protocol. And from that, they selected 16 of the best cases from all of their students and analyzed the results and published it. And they published, you know, fabulous results, but of course it was hand-picked cases and not a big random sample. One of the things I'll show you out of interest is the treatment protocol involved, down here at the bottom, involved modification of the LANAP procedure by cutting the energy to 1/3 of that recommended for natural teeth. And I'll show you a little later on the change that I did that seemed to work, and where we kicked it back up to almost exactly what you see on natural teeth. So our protocol for failing dental implants, the retrospective analysis of 222 patients from a private practice. As I mentioned, Dr. Harris, he's now with the Department of Biological Sciences at Cal State University in Chico, California. He's with the Department of Periodontics at Rutgers. And then he's with Biomedical Consultants out of Oroville, California. And thanks to Dr. Harris for his huge assistance to me in doing what I could have not done otherwise. And as I said, my contribution was simply to do the surgery. Now, how is peri-implantitis defined in the literature anyway? Well, it's any pocket 5 millimeters or deeper, or any 4 millimeter pocket with bleeding or pus on what? On probing. Now, that's interesting. I mean, this was published, you know, in the literature at the time I did my study. I can't remember when it was published, but I recall hearing many oral and maxillofacial surgeons saying adamantly, and lots of smart people too, by the way, not to ever probe an implant. So what's the truth? Do you probe or do you not probe? That's the question. Well, I will tell you, after having done what I've done, I'm adamant about the fact that you must probe, because there's no way to for sure know what's going on with that implant if you don't probe, or to gauge your progress along the way. We do use the non-metal implant probes, and I do have my hygienist probe every one of them. I probe them as well, but when you want consistency in probing technique and probing pressure, if you're gonna follow along with your progress. And I think she does push a little harder than I do. She usually gets a little bigger numbers than I do, but she's the one who does it every time, so it's consistent. So when do we probe? Well, the first time I probe, after I put an implant in and they come back for me to check them to see if they're ready to go to the restorative dentist for the crown to be made. We take radiographs, In the past, it was PAs or PANs or both. Now we're adding in the CT scan when there's peri-implantitis, but not just for the routine implant check before the restorative referral. We get a PAN or PA. I do a sound check, and we probe it. And if there's a pocket deeper than 4 millimeters, or 4 millimeter pocket that bleeds, I'm not going to send that to the dentist. I'm going to do a LAPIP procedure on that, and I'm not sending it out for the restorative work until I've got a healthy implant that meets the criteria of not having peri-implantitis. Then we're going to give them an appointment at that time to come back in 6 months after the referral is made to the restorative dentist. That gives the dentist a couple of months to get the crown made or whatever he's building on top of this implant, and then 4 months of function to see if we're going to have problems. And I found that most times, if you're going to have trouble with cement, or if you're going to have problems with hyperocclusion, or if you're going to have problems for whatever unknown reason, so often it will show up fairly quickly. And so we're going to get them back, and we're going to probe that implant then for sure. Now, what about no probing? Is there any time probing is out? Absolutely. And that's after the LAPIP procedure is done. You don't want to probe those implants during that first 6 to 9 months, because that's the time that bone is beginning to come back in, and you can disturb that process. I would actually like to see this extended even a little bit longer, and I'll show you why when we show you the rate of bone growth back into pockets after both LANAP and LAPIP is done. Is pretty interesting. So I've had to really spend time with my dentist and their hygienists, getting them to probe implants because they weren't doing it, and they weren't sending me, they weren't picking up and diagnosing peri-implantitis until it was too late. I mean, I've got a much greater chance of curing a 5 or 6 millimeter pocket of peri-implantitis than I do a 12 or a 13. Not that it can't be done, but the worse it gets, the worse the prognosis. And yet, finally, I get them probing these implants, and then they see one of my LAPIP patients, and they're probing them at 2 or 3 months just because I've taught them to do it. No probing on LAPIP procedures during those early months. So our retrospective analysis, we had from October 2013 through September 2016, we had 222 patients that met the criterion of having all the data points that he needed. And the statistician threw out all the others because they weren't complete with data. And these were the patients who came back. All the patients were told to come back, all of them, but we can't make them come back. And so between the ones who didn't come back and the ones who did come back, but we didn't have complete data, we were left with 222 patients with 437 implants. Random selection, mean age 65, 7 medical conditions were documented. And on assessing the peri-implantitis, we look at probing depth, bleeding on probing, redness, and pus. So 4 parameters: depth, bleeding on probing, redness of the tissue, and pus. So out of that group of patients, of 222 patients with 437 implants, there were 116 of the patients that had complete data with 224 implants for statistical analysis. The efficacy is defined by improvement in pocket depth at first follow-up was 103 out of 116, or 89%. You can see why I get excited. I mean, it's unbelievable. Reductions in probing depths was statistically significant with a p-value less than 0.001. And look at these secondary outcome measures. Bleeding was reduced by 78%. Pus was reduced by 83%. Erythema was reduced by 85%. We did have 6% of the implants that were lost or removed. Among the associated things that may have been contributory was medical conditions, severity of the initial clinical signs, age, and the female gender. So this was a paper that we ended up publishing. We since have looked at some longer term follow-up numbers, and that same group of patients then had follow-up through July 2018, And that increased our patients fulfilling the data points to 155 patients with 299 implants for long-term follow-up data. Dr. Harris tells me that this is the largest publication of work on peri-implantitis that's ever been published. That's what he tells me. I don't know if that's true or not, but I'm certain it is. We saw one additional implant lost at 30 months. Median follow-up was 24 months with a range of 1 to 63. 68% remained successful. So we dropped down because there have been 11% relapse at about 24 months on the average, and 16% that didn't completely respond, and a failure rate at 5%. Now, if you look at this on a pie graph, it'll help you see it a little better. The 68% you see on your left side is broken on the right side into longer term, which is 48% of those, and shorter term follow-up, 20%. We've got the 11% relapse rate, 16% partial responders, and 5% failed. I'm going to just show you a few cases of the different categories there. Let's take a long-term success case. Here's a patient treated in 2014 with pockets on the buccal of 7, 6, and 7, and on the lingual of 5, 4, and 5. And you can see they're getting better at 6 months. At 20 months, they're better now. I can tell you this patient is now 5 years out. This was an implant-supported overdenture on locator attachments. And radiographically, you can see the remarkable bone fill that occurred. That's a home run, just a home run. And it just, you can't, if you don't get excited over seeing that, your heart's not beating. And this is what I saw. I saw a few of those cases when they showed me, and that's what moved me here. Wish we could do this every time. Wish we could cure them every time like this and keep them cured and not have them relapse. But that doesn't always happen because sometimes there's long-term relapse. Now, you know, there's limits to radiography, and I've seen it with CT, I've seen it with PAs, I've seen it with PANs. Sometimes it's just hard to see what's really going on there, and that's why probing is so critically essential. Now, this case started out not too bad, and that's when you're not gonna see as good a radiographic evidence when it's just 4mm pockets that are bleeding on probing, which fulfills the requirements. So we started out, you know, 4mm pockets only, but they bled. So it met the criterion of peri-implantitis. We treated the case, and here at 12 months, you can see, man, the pockets are doing great, gone to 3 2s and 3s, and no bleeding, no pus, no redness, and great at 24 months. And then what in the world happened? You get to 36 months, and the thing blows up on you. And is now at 36 months worse than it was at the baseline. So long-term relapse happens sometimes. You got to follow these cases. That's why a strong follow-up recall program is critical, a strong hygiene program involving implants, even if you're an oral surgeon. And then sometimes there's a complete failure like we see here. I mean, like this case starts out with 10s and 12s on the buccal, and we treated it. It got better, but then it started going south. We retreated it, and eventually lost the implant at 30 months. You know, and this happens sometimes. And then here's an example of a partial responder requiring a second treatment and still not having a home run result. The case starts out at baseline with 9mm pockets all around. At 4 months, we didn't see any improvement at all. And, you know, we don't probe these cases at 3 or 4, 5 months, but what we do to assess that there's been not the improvement we wanted is we press on the gingiva on the labial. And if there's peri-implantitis there, almost every time you will see pus or blood express. And if that happens just from pressing on that labial tissue, there's no reason to wait. You got to retreat it, because if it's been 2, 3, 4 months and it's got that, it's sick. And so we retreated it, and boom, gets better at 15 months, looks great. Then 33 months out, gets sick again. So in this case, patient wanted to keep the tooth. We feel like it's going to be hard to maintain it long-term, but we retreated the case at 33 months. So an example of long-term partial response, requiring not only a second treatment, but a third treatment. So I mentioned bone, the rate of bone growth. And so this is an interesting slide I want you to see. Over on your left is a graph that the Nicholson paper showed. And these are their 16 ideal cases. And you can see on the left is the cross-sectional area of the defect. And then on the bottom is time. So you can see how there's a progressive filling of bone on the average through about 12 to 18 months, and as long as 36 months in some cases. And that curve is similar to what the average healing curve is around teeth that Yuckna and Nevin saw. And then if you overlay my information on it, it's interesting. First off, on the Schwarz data, what they did was they looked at the patients that were in there and randomly selected them, 10 cases randomly selected, to show the rate of bone growth in my cases. And they chose patients from each category, those that had relapse, those that had partial response, those that had failed, and those that had success. So the black are my patients overlaid over the Nicholson patients. And you can see the lost implant, you can see I treated it over on the left side, and it just skyrockets losing bone as it failed. Here, the one partial response, you see there's an initial improvement, and then boom, it starts failing. But then the rest of them, you see this progressive fill of bone that's similar to what the others have shown over time. So 24 months, 30 months, not uncommon to see bone continue to get better all the way through then with LAPIP and LANAP. Now, what Dr. Harris did is every one of my patients has a recording strip from the Millennium Laser that's put in the chart that documents how many joules of energy I gave for all the steps that I do. And he went back and statistically analyzed what it was that I did. And I found when I got back from my training that at 1/3 the dose given around teeth, to do that around implants, I couldn't get the pockets treated unless it was a case with real small pockets. Because getting the fiber, the glass fiber that carries the light beam to do the work through the tissue around an implant is way harder than it is around a tooth. There's something about the threads, the roughness of the surface, the adherence of the tissue against it. Doing LANAP around teeth is way easier for me than doing LAPIP around an implant because of that phenomenon. And so it takes me longer. I can't do it 3 times faster. It takes me longer. And so this was the energies that I end up giving. And I gradually, progressively increased to these levels as I saw no complications or minimal complications happening. Over the entire time I've done this, I've had 3 or 4 patients have some necrotic bone exposed, but very small amounts that healed well with time without lasting problems. And so as my boldness increased and my results increased and showed it, I increased my dosage to the levels you see here. This was the average for all of those patients in the study. Pass 1, 130 joules plus 10 times the mean pocket depth. Pass 2, 85 joules plus 4 times the mean pocket depth. That's what all of those patients were given on the average. The other thing is, instead of the J strokes where you go down and then move over and come up, that's taught around teeth in the LANAP, I'm not able to do that around the implant because I can't make that sideways stroke down in that pocket because of this issue with the tissue. So I do what I call sandpiper strokes, which is just down and up. I go down into the pocket, delivering light as I do until I hit the bottom. Then I come up and move over a little bit and go back down again. And I like to see that blood boil up a little bit out of the socket, and then I know I'm getting that action, and I treat the whole circumference of the tooth that way. And when I'm done doing that, those are the energy levels I find I've given. Now we did some cone beam. I mentioned cone beam. Just show you some examples. You know, the problem with the cone beam is the scatter you get from the metal. And so on cases like this, without deep pockets, you're not going to see a dramatic thing on the radiograph, even though it's a cone beam, and even though we did have really good results here in this case. When pockets get a little deeper, like here, you see 9s and 7s and 12s, and go to 3, 2, and 3, and you look at the radiograph, and it does show that quite well that bone did fill in where there was no bone before. And here's another case, a severe case. You can see the bone loss on the left, and you see remarkable fill on the right. My gosh, we've gone from 12s on all 6 sides. I mean, all 6 points to 1s and 2s in the matter of a couple of years. I mean, it's just fabulous result, and that's something to get excited about. Now, I want to show you a couple of, just the past week, you know, I saw a classic example of these relapse cases. Now, this is our data sheet that you see over on the left. How long have we been talking, Ray?
43 minutes.
43 minutes. We're good. If you look over here, you can see this patient had on the buccal 6s and 9s, and then had great results, goes to 2, 3, and 2, and same tremendous result on the linguals. And you follow it all the way down. We start out in January 2015. Everything is fantastic as late as July 2016. Then the patient quits coming in because, you know, I mean, we do charge for our hygiene visits, not a lot, but we charge something. And, you know, after he had several good report card results, he thought, shoot, I don't need to go in there anymore. And he wanders in here on August the 19th, not that many days ago, and he's blown up. He's got 6s on the facial. His distal buccal is 11, and he's got a 9 on the distal lingual. And you can see down here on this bottom radiograph, you can see it radiographically. Oh, it just makes me sick. And so we repipped him. You can see I gave 318 joules on the ablation setting and 158 joules on the hemostasis setting because his pockets were so deep. And I chose not to remove the crown. The dentist had cemented it and wasn't one of the better dentists I work with. I was worried about him getting an access channel to get the crown off. And on my first treatment, if I can get the probe in there without too much trouble, I'll go ahead and leave the crown on if it's going to be an issue to remove it. If I don't get success after the first treatment, then I will remove the crown before the second treatment, and for sure remove all crowns that are going to compromise my ability to do the job I need to do with that laser light. Just another example of relapse. We had a great result. 2014 patient had 8, 6, and 9 on the buccal, 11, 4, and 10 on the lingual. We took him to 3, 3, and 3, and 2, 3, and 3, and he was great through 2020. But look, he's on February the 20th. On February the 20th, he's 3, 3, and 4 on the buccal, starting to show a little concern because on the lingual he's 4, 3, and 5, but he didn't have bleeding, he didn't have pus, he didn't have redness, and so I was a little concerned. So we brought him back 6 months later on August the 3rd, 3 weeks ago or so, and boom, he's got trouble. He's 5s and 4s and 6s, 4s and 5s, and it just illustrates where this can happen at any time for any reason, and who knows why. You got to follow these patients to stay out of trouble. And even then, you can't always stay out of trouble. So in summarizing our LAPIP work, we've done 1,012 total LAPIPs at Valley Oral Surgery since 2013. And this is an interesting graph that I'm really proud of. I want to show you this because look what's happened, folks. I mean, I started in October 2013, so I only did 15 between then and the end of the year. Next year, 2014, jumps to 135, then 159, then 305. You know, and most of those are mine, but word starts to get out that you're the only guy that can cure some of these cases of peri-implantitis, and you start getting referral sources that didn't used to refer you implants. They referred them to somebody else, but their implants are getting sick. So what do? They hear you got a way to help them, and so they start sending you patients that you never seen them before from them. I mean, it's a fascinating thing. So that really kind of exploded it at that point in 2015, late 2015. And then it drops down to 125 in 2017, took a little bump up in 2018, and then the bottom fell out. I mean, in 2020, I've only done 36 cases. And so you can see how, and that's annualized, by the way, based upon the numbers where we're at now, what we project we will do for 2020. So why do you think that's happening? What do you think? Folks, it's working. I mean, I'm curing most of my patients and eliminating the need for retreatments in most of the cases. Not all of them, I showed you those numbers, but that's something that excites the heck out of me. And I mentioned how hard it is to get these papers published. I sent our paper that we wrote to a prestigious peer-reviewed journal in oral surgery, and they declined it because it was a single investigator retrospective study with success rates too high to be believed based on the current literature. I sent it to a premium perio journal, had the same thing happen. I was so discouraged. I was told by friends of mine, you know, you've never published anything significant. You don't have a name other than your master's thesis. And you know, retrospective studies are hard to get published. But we were about to give up, and Dr. Harris said, let's send it to General Dentistry, the HED's journal, and God bless them, they published it for us. And we're so thankful. And we've got a follow-up article that we're currently preparing. We're going to be sending out with that longer term data that I told you about. Now, I want to talk to you about biostimulation. This is an exciting surprise. I certainly didn't go to get this laser for this topic. But when I was up there, I heard them talking about biostimulation and how it enhanced healing and reduced symptoms, but they didn't have any evidence to show me. There's no science that they could show me in 2013 when I was there. But I got back and Googled it, and I saw this article in 2010 that had been published where I believe this was South Korea, where they showed the Nd:YAG laser induced BMP2 expression in osteoblasts. And that was pretty cool. And at first, the articles were trickling out on this biostimulation. 2015, high-powered Nd:YAG laser triggers osteogenesis of osteoblasts by activating BMP2 and insulin-like growth factor 1. And then, man, the door begins to break as there's more and more research being done. Low-level Nd:YAG laser therapy on human gingival fibroblasts. They showed it fired up the fibroblasts to do their thing. In this case, proliferation and growth factor secretion. And then this fascinating paper, 2017, where they showed that the Nd:YAG laser accelerated differentiation of osteoblasts to osteocytes on smooth and rough surface titanium surfaces. How cool is that? And since then, like I said, there's just been an explosion of research on this topic. Many have urged the chain to change the name from biostimulation to photobiomodulation, but it's the same thing. And there's science now that proves all of these things happening. You know, primary and secondary biochemical effects and cellular effects, including proliferation, migration, adhesion, angiogenesis, collagen synthesis, neovascularization that cause clinical consequences that you're looking for, including pain relief, reduced inflammation and edema, and enhanced wound healing and tissue regeneration. And like I said, when I was there getting trained, I heard them talk about it. I heard them show it. I got back to the office and I told Liz about it. This lady I told you about that's always pushing me to be better and to get better and stay ahead of things. And after about the first 3 or 4 months that I was back here in the office, she said, "Doc, why don't you ever do any of that biostimulation that you told me about?" I said, "Liz, I don't want to charge somebody for something that I don't even know why or if it works really or not." She said, "Who said charging them anything?" She said, "At least start trying it and offering it on one side and not the other side so we can see if there's a difference." And of course, this was before I saw all that science, other than that first article that I showed you in 2012. And So we did, and we were amazed, just amazed. And I'm going to show you what has happened in my practice with that. Uh, we started doing a procedure that we termed decon biostim. Decon meaning decontamination. Biostim, you know what that is, biostimulation. And I started talking about this and reporting on this when I lectured for Millennium back in 2014. And they have since trademarked the name BLAST, which I'm not sure what that stands for, but the BLAST is a name for decon biostim. And I use it primarily for socket grafting and immediate implants. When I'm taking a tooth out, I'm going to put a socket graft or an implant in. I'm going to come in first pass and deliver to 125 to 200 joules set on the ablation setting. What am I trying to do there? I'm trying to sterilize that socket. The same light that kills those bugs in that pathogenic pocket can be killed in the socket that you've created by taking a tooth out. And doing that not only is going to kill bugs, but it's going to cause some biostimulation as well. Then the second pass, which can be delivered by my hygienist, it's a lower energy setting, and she's been trained and certified in this, delivers 250 to 300 joules on the intraoral biostimulation setting. Now, just showing you how this can work and how this looks. One of the things I lecture on is the flapless removal of fractured off roots without bone removal or any flap through the use of approximator and a mallet. And we teach this procedure, and you're able to get the tooth out with no incision, no bone removal. Then we come in with a laser light set on ablation, sterilize the socket. Then we pack the socket. In this case, I'm using Puros, which I really like. And then the collagen plug on top of it, and the suture in place on your left on the day of the surgery. On your right is this patient 1 week later. Now look really close and you'll see through this blood clot and saliva that's on top of this, you can see the pink of the gingiva growing in towards the socket, filling it in from the periphery, literally 1 week later. And this patient had zero pain. It takes the pain, it helps remove the pain from the injection sites, especially on the palate and in the mandible, and accelerates the healing. It's truly remarkable. What about impacted third molars and decon biostim? I'm just here to tell you, I ought to be doing it. My problem is I've just got 2 machines. And I mean, that machine is being used constantly by either myself or my hygienist. I have one for my lower valley offices, and I have another for my upper valley offices. I'm getting ready to add 2 partners. I don't know how many machines we're going to need, especially if we start doing third molars, but there's no doubt in my mind that it would reduce their pain, probably reduce dry socket incidence. And I just haven't been able to apply that yet because it's just overwhelming what I do have so far with what we're doing with it. Now, I want to show you this. This is unbelievable. David Harris called me about 3 or 4 years ago and wanted me, he knew I had a large TMJ practice. I see probably 5 or 6, 7 patients a day for TMJ and evaluation, TMD. I'm, as far as I know, the only TMJ surgeon in South Texas, but I mean, I only find 4 or 5 patients a year that I can't help with non-surgical methods. And so I do as little of that as possible, using a tool chest of things from Botox for the patient with the hypertrophy of the inferior belly of the master muscles on occasion, to splint therapy, which is the nathologic type splint, Pankey type splint, or Dawson type splint is hallmark of what we do for these patients. But the other is this thing that with the laser. David told me there was a man he was working with, a doctor, who was having remarkable results, and he wanted me to participate in the study with him. And I said no, because it didn't make sense to me. I couldn't imagine it working. And so about a year ago, no, about 18 months ago, I had a patient I'd done a mandibular advancement on, and nothing I was doing was working anymore. I had managed her with a splint for years. I did arthrocentesis on her, and it initially worked, then it relapsed, and I got to where I couldn't help her, and I was going to send her to Dallas for total joint replacement, because that's the one surgery I won't do. I can't find enough of them that need it, because I don't want to be doing a surgery that I do once every 2 years. So I refer those out, and it's extremely expensive. She started crying. And once again, Liz says, Doc, why don't you try biostimulation? I looked at her with a funny look on my face. I said, did I tell you about what Dr. Harris told me? And she said, no, I didn't hear. I said, why did you mention it? She said, it makes sense. And right again, you know, I turned to my patient. I said, I don't know if it'll help you. It doesn't make sense to me that it would, but if you can't afford the total joints and you're desperate, I know it's not going to hurt you, and I'm not even going to charge you. So she said, okay, do the worst side. So my hygienist is also able to do this because it's biostimulation, low energy levels. I started taking out some wisdom teeth and seeing other patients in this open clinic. And about 30 minutes later, I heard this scream, and it scared me to death. I jumped up and ran over there to see what happened to her. She was sobbing. Her pain was gone on that side. And she said, would you please do the other side? So we did. She screamed again, and she was great for about a year, and then started hurting again. That was about 6 months ago. We treated her a second time. She's still pain-free. So then we started waking up a little bit. And we give 35 to 4,500 joules that are delivered over the symptomatic area, muscles and joints that are symptomatic. Mobility and pain changes were written down, unrated on a scale of 1 to 10. And so far, the results, of course, this isn't a scientific study. It's just for my own knowledge. 32 patients have been treated. There were 2 total failures, not any help whatsoever. One was a lady that hurt all over. She had fibromyalgia. And the other was a case that really needed total joints. There was horrible arthritis in the joints. It didn't help her. But 29 incredible results, including this.
Dude, I heard it work. It's unbelievable. I can't believe it. It's like a miracle. I can't believe I'm back to normal. I can talk. I can close my mouth. This is, I've never been so surprised in my life.
Were you the first time I tried it? Because I didn't really, you know, for me, I was a non-believer. I heard about this. I was asked to participate in a research on it because I had done other research with this incredible technology with other topics. When I was told it would help TMJ, I'm the only TMJ surgeon in South Texas. So I see a lot of TMJ patients. I know the subject well, and I couldn't understand how the biostimulation from this could make that big of a difference. But it does.
Oh my God, it sure does. I'm so happy.
Then you look like they have to be.
This way says Friday, so I was like, hey, believe me, anybody ask me, I'll say nothing.
That's great. Thank you, Robert. So have a good day.
You too. Oh man, my wife's gonna be so surprised.
I love that ending. That wasn't planned, obviously. So, but we do have planned as a prospective study, detailing data sheets on this and where we can analyze what's really going on here with TMD. Ablation of hemangiomas. I'm just going to close with a few other things about how we've used this. There's no other tool I know of for treating something like you see on the upper left side of your screen and right side of your screen. That's it. The lip side of a giant hemangioma, and the outer lip and the inner lip, showing you what was there when we started. And it was so big, I knew it was going to require so much energy that I made no attempt to do this in one treatment. But I did 4 or 5 treatments over a period of time. And you can see on your left is the intraoral side of things before and after treatment. And here, the extraoral side of things. I mean, it's changed his life. His wife will actually kiss him now, and she wouldn't even think about kissing him before. She thought he looked like a monster. I mean, that's unbelievable. That's a miracle. And he didn't have hardly any pain, didn't have any bleeding following the treatments. And you can take these small hemangiomas, and in 30 seconds, it's remarkable to watch it. It turns from blue to white, and it goes from convex to flat. And tremendous service. No other tool is going to do that right there. I want to talk to you a little bit about our hygiene program at Valley Oral. There's a procedure called laser pocket disinfection that Millennium has developed. It's lower energy settings, excuse me. But your hygienist, at least in Texas, can be certified to do this, along with the other things I mentioned to you, by going to a course and being certified in it. Laser pocket disinfection kills bacteria, disrupts biofilm, helps reduce inflammation, maintains healthy gingiva, and prevents progression of peri-implantitis and mucositis. The laser light can reach and destroy bacteria up to 6 millimeters beyond the surface to help prevent bacteria from spreading back into the pocket. And this comes from a packet, a little packet flyer that Millennium developed that we give to the patients. And these lower levels can be delivered by hygienists with proper authorized training, and it delivers about 70 to 100 joules of energy. Fees typically range between $35 to $75 per implant. The code we use is 6199. I'll show you that later on. But this is done by my hygienist when she recalls the patients for implant evaluation. Now, talk to you a little bit about our recall program at Valley Oral. First, on all on fours, at a week, she gets them back and irrigates under the prosthesis with a monojack filled with Paradex and gives oral hygiene instructions, no water picks on all on fours in the beginning. Then we bring them back at 4 months, and my hygienist removes the prosthesis and cleans the prosthesis and the implants and the gingiva using LPD and biostimulation as needed. She probes the implants, sound tests, and then has me retorque the abutments. Then at 6 months, at 4 months, we then send them to the dentist to do the restorative. And by 6 months, they should have the final prosthesis in. At this stage, we don't remove it, but we evaluate their hygiene and check their occlusion, because a lot of these cases, as you know, they won't have the occlusion right. You're going to have trouble if they don't. So we don't remove the prosthesis, because it hadn't been in there that long. So we then bring them back 9 months, and then every year we bring them back annually to remove the prosthesis and proceed as described at 4 months, where prosthesis are removed, clean the prosthesis, clean the implants with LPD, stimulate the gingiva if needed, probe the implant, sound test, retort. Now, if there's problem patients with hygiene that you're worried about, then we recall them more frequently at 3 to 6 months instead of annually. So that's for the all-in-fours. What about the routine implant hygiene program? Well, we see them every 6 months on the average for probing, occlusion check, sound test, and laser pocket disinfection. Problem patients more frequently. Now, what about the LAPIP hygiene program, or hygiene program for LAPIP patients? She sees them 1 week later to check healing. We see them 3 months at the midway check, no probing, as I told you before, but we press against the labial gingiva and see if there's any pus or blood to express. If there does, then I see them myself, and then we retreat them. Most of them, you don't see that. At 6 to 9 months, now we're ready to probe them. A CT is taken, probe the implant, check the hygiene, and document the findings. Now, I want to, y'all that are watching this, you might want to take your camera. I'll leave this on here in a second. You're going to see some numbers that show the production with this laser in my office, and you'll see it doesn't go back to 2013. And the reason is it took me time to figure out codes to use for all these different things that we do. These, like I say, these are procedure codes that are used. 40820 for laser ablation of hemangioma of the lip. 41599 for ablation of hemangioma of the tongue. 4260 for LANAP of 4+ teeth. 4261 for LANAP of 1 to 3 teeth. 6080 for all-on-4 LPD, which is a miscellaneous all-on-4 code. 6101 for LAPIP, which is a miscellaneous peri-implantitis code, and 6199 for LPD. And I'm going to show you the miscellaneous codes for biostimulation in a minute. In talking to my insurance department, what they're finding is LAPIP is being covered more and more and more by insurance carriers, and certainly LANAP, which is paid just like a flap perio procedure. Hemangioma ablation, we've had luck with insurance, or not, I'd say luck, I'd rather they not cover it. But LPD, and biostimulation, most of the time those are not covered by insurance, which is fine with us because if insurance covers, they're going to cut the stink out of your fee. But we still have to check with them, obviously. These are the most miscellaneous procedure codes for biostimulation. You can see the numbers on your left. Leave that a minute for those that want to take a picture of this. The top one is decon biostim together for one tooth. The next is decon biostimulation for two teeth. The next one is biostimulation only. And then decon biostim per quad, decon biostim per arch, and then biostim per quad and biostim per joint. Then, of course, the bottom one is for the TMJ treatment. And these are miscellaneous codes as well. So hopefully you got a picture of that by now. Let's move on. I'm going to show you now production at VOMS with a Millennium laser. And you'll see it starts at 2016 instead of 2013. So the production has actually been higher than this. We just didn't have the codes where I could go back into my computer and recapture this stuff for you before 2016. You'll see on the lower right, LPD and TMJ biostim. Those are just recent additions to what we're doing with the laser. Moving on, here are the numbers for production with this laser during just a 4-year period of time, from 16 to 20. LANAP is not something I push. I really don't want to be a periodontist. I don't want to treat perio. We've got great periodontists here in the Valley for that. But the fact is, there are patients that do their research and they want the non-surgical flapless benefit that LANAP offers. Its success rate's very similar to a skilled periodontist doing flap surgery, but with a whole lot less morbidity. And so I get people that call me and refer patients to me and want me to do LANAP for them, and none of the periodontists here have the Perlays. At least I haven't at this point in time that I'm aware of. LAPIP, 423,000, that's a lot of production, but you saw from the graph I showed you that those numbers are falling quickly. Biostim by itself, 284,000, with decon biostim, 768,000. And then these recently added procedures, LPD is going up fast, and that's a lot of money for a procedure you can just charging $35 for, if that. And then TMJ biostim, that's also a recent procedure, quite a bit of production for that, just over a short period of time. So is it a big expense? Yeah, but not near the expense it used to be. But even at what I paid, my gosh, I've returned my investment many times over since I got trained in 2013. And I'm going to be buying some more machines, I can assure you that, and sending my 2 new partners up for their training and certification. The impact on my practice from this technology, where are we on time, Ray?
You got about 10 minutes.
Okay. You know, it's the first protocol with a high probability of success for peri-implantitis. I mean, you can't find, I don't think, an article published this big that's got these success rates. And I promise you, there was zero bias in this study as the IRB approved. It doesn't involve a long, expensive surgery. It has minimum negative sequelae for the patient. And it gives me hope for those cases that are falling apart on me. It gives hope for the patient. And hope for the general dentist. My gosh, you know, when you're the surgeon and you place an implant and it starts going south, you've got not only an unhappy patient, you got an unhappy general dentist who might be having to look at redoing some of this, and who's going to pay for it, who's not going to pay for it. And that's stress, man. And so reducing stress for all of us is something I'm all for. And it's provided major practice growth. But, you know, along the way came these surprises. I went up there to help myself cure sick implants, but I got these bonus surprises called decon biostim and the TMJ benefits. And then the benefit of incorporating a hygienist into my office. I mean, I never even thought about who ever heard of an oral surgeon having a hygienist. And now I don't know how I'd spent practice without one. And she doesn't clean teeth. She doesn't compete with the dentist. One of the things I was worried about was, would this create a problem for me with a general dentist? Because hygiene program is really important to them. And it doesn't. They love it because they don't want sick implants any more than I do. And they love us following our implant patients and sticking to that. That's what my hygienist in my office is for, not for competing with the dentist. Right. I'm not, oh, there it is. I mentioned my ranch to you. My passion started out whitetail deer, and if you Google my name in whitetail deer, I didn't get any photographs of that, but growing giant whitetails is what put me on the map nationally and led to us having one of the longest running outdoor whitetail deer hunting TV shows on TV called Bucks of Tecumseh. Jeff Foxworthy was my partner for about 7 or 8 years, and it's been on TV, and it's on the Outdoor Channel now for probably close to 20 years. But my passion shifted, probably 12 years ago now to building these big lakes and trying to grow giant bass. And we've been featured in a lot of magazine articles that predicted that we're the best chance to bring the world record back to the United States. This is the most recent lake I built, Jalisco Lake. On your left is a 60-acre lake, the main lake. In the middle of it is a wetland that I developed. And then on the right are these forage ponds, of which there's 3 then, there's now 4. I built a 4th one up there. So it's a 60-acre lake with 30 acres of forage ponds to enhance their nutrition. And I grow Indonesian prawns in these ponds and bluegill that are able to grow without being eaten by the bass until they get big. And then I designed these drains that have big valves on them that you open down below. And this lake runs into this lake when I'm ready to feed the bass, and takes the prawns and the bluegill with them to feed these bass. And what's funny is after you're doing that, every fish you catch has these big antennas and claws coming out of their mouth and out of their anus. It's hilarious, but it really makes a difference. This is my family. This is a picture quite a while ago when I was quite a bit more weight on me than I have now. But my wife and my 2 daughters and my son and my grandkids, of which I've got 6. And after this, I was injured in a car wreck in 1989. I crushed my pelvis and my back and hurt my neck real bad. And I had chronic pain and didn't think I could possibly work out. And believe it or not, that's me. That's at the ranch at one of our Seattle Study Club gatherings. I think Bob Mergale was there lecturing at that time. And my buddy back behind me there, he took this, had somebody else take this picture, and they got it and sent it to me. And I saw that, I was so embarrassed. I thought I looked like a hippopotamus. My neck is almost as big as my shoulders. And I had sleep apnea, and I had hemorrhoids, and I had addicted to Afrin nasal spray. And I went to my doctor. He said, "You're a physical wreck. You've got to do something." And I said, "I can't." He said, "Well, it's just simple. Eat less or eat better and exercise." And I said, "I've tried both. I can't exercise because of my pain, and I can't eat better because I just can't." And he said something magical to me that I've since used on patients. It really works. He said, "Look, if you can't do it for me," he said, I know you're a dentist because you like to make people proud of you. Same reason I went into medicine. And he says, it starts with your teachers, making your teachers proud, making your parents proud of your report card, and then making your coach proud. And now today it's making your patients proud. And he said, so if you can't do it for you, do it for me. Change your body and come back in 6 months to a year and show me a new you. And I don't know why, but something clicked. And so a few years later, I went to the Senior Olympics, and I was leading in the long jump for the gold medal until the last jump, and that guy beat me by about 3/8 of an inch. And I just hate being second. Second's first place loser, but it changed my health and eliminated my high blood pressure, my cholesterol problem, my triglyceride problem, my liver problem. Everything went to normal. And then next thing you know, after being good about staying in shape for 5 years, I had some stresses come my way that I had to deal with. And The IRS audited me on the ranch, saying it's a hobby and not a real business, which is ridiculous because it makes more money per acre than any ranch in Texas, and I'm there every weekend working myself on it. But doctors are targets for hobby enforcement, and so I've had to appeal it, and I'll win, but I'm having to fight it. And so the stress of it's been going on for over 2 years. I just didn't feel like going to the gym anymore, and I went south again. And my wife finally, about right before the COVID outbreak, she said, "You're going back to Gold's Gym. Sign me up for the 12-week challenge." And the 12-week challenge is something that they take a picture of you like you see here on my left. That's how I was back a few weeks before the COVID shut down. And on the right is how you are after 12 weeks. I'd actually won it twice before and placed second once and third place once. And then I drifted away for 2 years, but I'd never won more than my gym. But this time, competing against all ages, I won the local gym, I won the whole valley, and then I won South Texas, and then of all things, got second place in the nation. There I am, second place again. You know, I was second place in my dental school. They call me second place Schwarz. I hate it, but my health's back. I got my blood pressure's right again, my liver's right again, and I was able to take a $4,500 check home to my wife, who suffered as well, having to cook special foods for me and putting up with me getting up at 4:30 every morning, and my trainer, who made me want to make him proud, just like my doctor. So with that, I think that's the end of it, Ray. Damon, I believe we might be ready for questions. Ray, can you bring them back up on the screen so I can see them? How long did I go?
You went 20.
There we go. Hey, Gary, great presentation. Really enjoyed it. And wow, you've got a lot of experience with both those procedures, and it's not everybody has that under their belt with anything we do in dentistry. And when you have that, and you're hands-on, and you've done it, it's real believable, and it's amazing what you can do with patients with this technology.
Thank you.
I've got a few questions for you here, if you want to proceed with those.
Sure.
You mentioned Millennium does training, and I know a lot of the companies that I had relationships with over the years, and that our leaders or authors do. Everybody out there that wants to do these things. Training is huge, and some will say they give you training, but it's a couple hour shot or one evening and you're trained, right? There's quite a bit of training that Doctors Bob and Don Gregg require when you're about to learn their equipment and really try to get started on these procedures so you can then become really proficient. Can you tell us a little bit more about the details of that training?
Oh yeah. First off, they ship you these manuals. I mean, big manuals full of research articles on just everything, and you need to read that stuff and try to get as much of it in as possible. And I want to go back through the training again. I told Dawn and Bob the other day, maybe even go get certified to be a trainer myself, so I can. So I'm hungry to remember all that stuff. There was so much there, you can't retain it all, but it really helps you understand things better, and it's fascinating. I mean, from the physics of lasers of all kinds to all the research papers that are there that back up what they've done. And then they all have someone there to teach you that's just a fabulous, smart lecturer. Like I was blessed to have Ray Yucknell was the one who taught my course. And so they teach you during the days. And then you get up at the end of the day and you go and you do hands-on training on live patients. Now, and you're trained by instructors there. You have an instructor assigned to you to walk you through the procedure, and you do the actual procedure working on a patient they provide. And so I trained on patients doing LAPIP, which is the technique, the protocol for teeth. And they didn't have implants for me to train on, but like I said, with those few modifications that I discussed, it's the same thing. And certainly attention to detail on the occlusion. So you do an occlusion analysis and occlusal adjustment. And I mean, it's just, and first you go up, and I think I went 3 different times. I had to go through 3 different and I think each time is like 2.5 days. And at some point midway through, you get your machines sent to you, but they set it at a lower energy setting, and you don't get to use it like full blast until you finish that final one, and then they up it for you. You got to send it back. But I mean, they do it right, and because this is working on people's serious business, and you can hurt people if you don't know what you're doing. And like I say, lasers are highly regulated by the government because of the danger of them, and so I think it's appropriate.
Great. Yeah, it's a commitment, to do these things, but it's no different than those of us that have been through continuing education courses far beyond, our graduation, whether it's the Dawson Academy or COIS or SPEAR or all these, right? It takes time. If you're going to, it's no different than the time you commit then to go and share things at the Seattle study clubs. How about this? Do other lasers work to treat peri-implantitis?
Well, that's why I went through. There's no paper that anybody can show me that's ever been published that shows any other laser having consistent success on peri-implantitis. It's not there.
It's the only one.
Yeah, I mean, if you want to ask me evidence-based, FDA cleared, no, there's no other one. There's no other brand of an YAG that has that I'm aware of. And there's certainly no other laser. I mean, diode's not going to work for treating peri-implantitis and having consistent success. Why? Because of what I went through in the lecture. It doesn't have the proper wavelength. It just doesn't have all those things. I said, why? What are the things a laser must have to treat peri-implantitis? And I listed them out and explained what they were. And if you don't have all those things, it's not going to work consistently. You may have an occasional success like the literature showed, but not consistent success. And you might really hurt some people because you're gonna burn up some bone or burn up some soft tissue because you don't have that therapeutic index protection.
A couple other questions that popped in. I think you might have covered this one. I think you showed codes. Does insurance cover laser treatment for peri-implantitis? Well,
that's there at the end. I was saying that in my staff, I asked them right before this course, right before I walked in here, because I don't get into that myself. My staff handles that, but I said I'm going to be showing codes. How often does insurance cover these things? And they said, well, more and more we're seeing LAPIP be covered, and certainly LANAP is covered as a general rule because LANAP falls under the same code as flap perio surgery. But LAPIP is being covered more and more and more. Biostimulation is not often covered, and laser pocket disinfection is not often covered. Hemangioma treatment is often covered. So it depends on certainly the code, and it depends on the insurance company. But as a general rule, about 50% of the time, insurance is covering these things, and 50% of the time it's not.
Okay, and that can vary from obviously policy to policy.
Sure.
Sure. Another question came in. I'm not going to use the full name because I don't know if we have permission to use names on these questions, but he did identify himself. It's a Dr. Tom. He said, would you please explain the settings used in the first and second passes for LAPIP? I've been a long time LAPIP user, but reluctant to do LAPIP. My concerns were the possible pitting of the implant surfaces.
Okay. Well, first off, yes, you're going to pit the implant surfaces if you aim the beam at the implant, and it'll make a nasty noise. But you don't want to go in 90 degrees to the implant. You don't even want to go in 45 degrees to the implant. You want to go in as parallel with that pocket as you can. And I'll be honest with you, I don't memorize this. I haven't memorized the settings for all the different things that we have the laser for. What I have is Millennium has the settings recommended for all the different things that we do, and my hygienist is responsible for checking those and verifying through calibration that we're at the right energy setting before I do a procedure, and she handles that. But you can contact Millennium and they will tell you the settings for LAPIP, and what they recommend is what I use. And then certainly, like I said, in how you use it, You don't want to direct that beam against the titanium where it'll pop and it'll pit it.
Okay.
And so no matter what your setting is, you're going to mess up. And so proper technique and the right settings are both important.
Okay. You mentioned your hygienist quite a bit, and it seems like you have a, and this is a question for me, you really, really work tight with your team and put a lot of responsibility with your team. Is that something over the years that you had to develop and or is that, where did that come from? Did Millennium say you should do this with hygienists?
No, you know, my father was a huge influence on me, and he was in the produce business and ranching business, and he believed in the value of people that are around you and empowering them and encouraging them and using them. I have apparently one of the very biggest private practices for oral surgery in the United States, and it's because of my team and what they do to help me. And they've been with me a long time. They're smart. I encourage them to be my highest critic. I want them questioning everything I do. I want to make sure we're taking the right tooth out. We've got the laser set the right way. It's not about my ego. It's not about their ego. It's about the patient. I want to focus on the patient, and we're a team treating that patient, and we want to not screw up, and we want to love on them and make that patient feel they were really cared well for. And that's what my team does for me. And I'm really good at delegating, and it's worked for me, you know.
You have a good sized team there. Gary, I noticed in one of the initial pictures, I think that was you and your team, right, at the stage.
Yeah, we've got 15 going to 16 employees, and of course when I add these 2 new associates, it's going to get crazy around here. But I go to McAllen, Wesco, Harlingen, Brownsville, South Body. I go to 5 places, just me. And this team travels around with me, and we just have a blast.
Fantastic. And still some time to raise bass.
That's right. And deer and doves.
One last question I have here. Sorry, I didn't mean to interrupt. My speaker's cutting in and out. I'm not going to ask the guys to fix it because I don't think they can. Can you use this laser for soft tissue surgery? Was one of the other questions.
Yeah, you can, but I don't. I'm not a big fan of it. You know, I've checked it. To me, I can do it faster and better with cautery. If I had an erbium YAG, or that'd be different. Those work great. But you know, I use this laser for what it was intended for, which is the selective destruction of pathogens through its wavelength magic to enhance healing, to shrink hemangiomas, not to cut soft tissue. You can do it, but I can do it way faster, I think, and way better in other ways, you know.
Okay. I think that wraps it up. I don't see any other questions on the board, and we really appreciate your time, Gary, and everything you're doing for dentistry and for your patients. And it's just been a pleasure to get to know you a little bit today virtually. I don't know about you, but you know, they keep talking about the new normal. I sure hope the stages come back without the mask. We can see the smiles, hear the heartbeats of our attendees, and connect like we do and always have in dentistry, despite very lethal diseases that we worked through in your lifetime and mine since we graduated in 1978. So yeah. Hopefully things will restore to, in my mind, and I wrote my editor's page coming up on that, my op-ed. I'm not satisfied with the new normal. I know there's things will change, just like always things change, but.
Well, I agree with you. I was so happy that TMJ video I was able to shoot for you happened just before we had to start wearing masks, or I wouldn't have been able to show that.
Yep. No, that's right. No, the smiles are important. They really are.
Amen.
We need to see them. Yeah. Yes, sir.
Well, God bless you. Thank you so much. And thanks all of you that attended. I hope you enjoyed it.